From 12 News, this is Newsmakers.
Primary care in crisis. The abrupt closure of Anchor Medical Associates has forced roughly 25,000 patients in Rhode Island to hunt for a new doctor and put a bright spotlight on a problem that's been worsening for years. What can state leaders do to address the issue, and when will it get easier to make an appointment? We'll ask two leading Rhode Island physicians this week on Newsmakers. Welcome to Newsmakers. I'm Tim White alongside 12 News Politics editor Ted Nesi. Joining us for this conversation on the primary care crisis in Rhode Island, we have Dr. Mariah Stump right to my left. She is the vice president of the Rhode Island Medical Society, and Dr. Thomas Bledsoe, he's the past president, right, of the Rhode Island Medical Society, and they're both primary care physicians. Thank you very much for joining us on the program.
Have to see patients right after the interview, right?
Yeah, so we won't keep you here
already.
too long. Have you already seen some this morning?
Yes.
Wow, you are squeezing them in.
Yeah.
All right, well then, that kicks off the topic nicely. I am curious, and Dr. Stump, will start with you, and I want to hear from you, Dr. Bledsoe, briefly. How would you describe the state of primary care in Rhode Island right now?
So unfortunately, I think we're in a state of emergency with this. I mean, since my time in training, it's unfortunately gotten worse and worse. You know, we have patients every day trying to get a primary care doctor, and unfortunately, we're all at capacity.
So you're not accepting new patients?
We're not taking new patients at the time, which is really sad, because I'd love to open our doors to everyone, but we're just, there's too few of us and too many patients that don't have physicians right now.
And Dr. Bledsoe, you've been practicing for over 3 decades. So, yeah, well, but that's important for perspective here. You know, she called it an emergency. In your 3 decades, how does it compare to years past?
Well, when you ask a question to me and you say briefly, it's always a challenge. So I'll just say that up front. And a tale of two cities, the best of times and the worst of times. So back in the day, I started with my medical assistant that I worked with for almost 30 years. And it was she and I against the world, and it was just us, and we had no support. Over the last 15 years, this Rhode Island has developed this advanced primary care practice model, where it's a robust team that takes care of patients. So that's the best of times part. The problem is the support for that is at risk now, and the people who are doing primary care, seeing the patients, unfortunately, are of an age where either have recently retired or are about to retire. And the emergency is that the 25,000 is really the tip of the iceberg.
Okay, so you're referencing Anchor Medical Associates, which we definitely want to get into, and the impact that has had.
Well, and I actually am curious, and I'll let either one of you speak to it, but I've heard reports that, you know, we think of Anchor Medical closing as a crisis as it is for those 25,000 patients looking for a new doctor quickly, includes pediatricians along with PCPs. But I've heard it's also become in a way a crisis for the other practices, because you're getting flooded with people. Is that accurate?
Correct. Yeah, that's exactly what I was referencing. You know, now that Anchor's closed, just that weekend after the Friday announcement, I must have gotten about 10 to 15 text messages from colleagues and friends like, my mom needs a PCP now, my daughter, my husband, my wife. You know.
And those are just people with your cell phone, right?
Exactly. Those are just people who have my personal contact info.
Dr. Bledsoe, you've been in this a long time. You must know a lot of your peers and colleagues, and particularly with your leadership position you had in the Medical Society. One question we're getting over and over, I'm curious if you have any insight, is where are all these doctors going at Anchor? Because, you know, the doctors won't go poof into the sky the day Anchor closes its doors. Do you expect a lot of them are retiring? Are you all bringing some of them into your practices? What's your understanding there?
So that's a question that I don't know the answer to yet. Certainly some of them are going to take jobs elsewhere that have better support. So Rhode Island is competing with neighboring states, but also competing with the rest of the country. Brown University, nationally known residency program, medical school. People have open doors when they finish training here. And keeping them in Rhode Island requires something other than just being married to a Rhode Islander. Of course, that often works. But we need a better plan to attract, retain the best and the brightest in Rhode Island.
So what is like the primary reason that we're in this crisis? You know, is it the medical infrastructure here in Rhode Island, or is it something that we have spent a lot of time talking about on this show, from the Attorney General to the Speaker of the House? We had the CEOs of the 2 major hospital groups on this program just a few weeks ago, and it was reimbursement rates, reimbursement rates, reimbursement rates. Is that the primary thing?
I think that's a large part of it. You know, when I have colleagues who, I mentor medical students and residents, and they're out job searching, and I'm like, come to Brown Medicine or come to other Brown practices or just Rhode Island practices. They say, well, I can go across the border and make 30% more, or I can go to Connecticut. So I think when
30, is it really?
It's really 20
more
to 30%
if you left, if you went from East Providence to Seekonk, for example?
You know, ish in that ballpark. So, and so I'm trying to tell them about the intrinsic value of staying in Rhode Island and those types of things. But at the bottom line, when they have student loans to pay off and they're trying to support a young family and they're busy, I think it's hard to convince them to stay in Rhode Island when we can't pay primary care doctors more.
Why don't we hear from the governor on this? So Dan McKee was on 12 News at 4 earlier this week, and our colleague Kim Kalunian asked him specifically about reimbursement rates. Take a listen.
Governor, is it time to stop studying the issue of reimbursement rates and just raise them so we can be more competitive with Massachusetts and Connecticut?
Well, on the anchor thing, we want to make sure that patients and the doctors get attached to other providers, and we're in the process of doing that right now. On the areas in terms of reimbursements, we for the second year, we have put in our budget, hopefully the General Assembly does pass it, which was is a review of the rates. That's the first step to doing something. So you have to get the information before you can actually determine what the remedy is. But I think raising the rates makes sense.
Governor Dan McKee on 12 News at 4 earlier this week. So Dr. Bledsoe, putting in money to review the rates, and that's probably going to take, well, you know this.
I looked at the budget documents last night. It would be it's due in September 2027 if this gets approved, and the rates, if I understood it right, might not take effect until 2028.
So Dr. Stump and I are scientists, and we take care of patients. We like data. We like to make decisions based on data. We've been talking about this bubble of physicians of an age who are approaching retirement, and we've been watching physicians leave the state and practice. So more study and years more, 25,000 today, how many more in December, how many more in January? Three of our colleagues left our practice, 2 retired and 1 took a job at the VA. So in our practice alone, we had over 3,000 patients that we needed to absorb.
Wow.
Part of our problem with the anchor patients. So this needs action now. The Medicaid is it's federal government money. There's matching federal funds for state expenditures on Medicaid. So a $90 million investment in Medicaid by the state would lead to $180 million of federal money supporting the Rhode Island economy which is what
the hospital executives were pitching when they did.
And just real brief, it sounds like what you're saying in response to the governor is we have the data. We don't need to review the numbers anymore. We already know what they are. Right? I don't want to put words in your mouth.
No, I think that's correct.
Okay.
So when I think about how we pay for health care in any place, including Rhode Island, I think of the 3 buckets of the commercial insurers for people, have a job and they have Blue Cross or something. Medicare, which is all federal, so Rhode Island policymakers can't change that directly. Then Medicaid, where the state sets the rates and then some federal money comes in with it. We're talking here about the Medicaid rates, right? Because that's the lever that's taken, or are we also talking about changing the commercial rates for primary care in Rhode Island?
Both.
Both.
All of the above. Medicaid is particularly acute, and folks who rely on
low.
Because it's so low. It's so low. Some of the pediatricians have estimated that every visit they see, they lose a little money on. So I forget the old W.C. Fields or somebody, I lose money on every patient. I just need
to volume. Yeah.
We have to go to a break, but before we do, I'm just curious, Dr. Stump, you said that you're not accepting new patients right now. You guys you have a lot. How many patients do you take care of? How many are under your umbrella?
So my former practice, which I just moved practices a few months ago, I had about, Pamela, 1,400 patients.
Okay.
I think that's pretty average for primary care doctors.
Was that full-time clinical, or were you doing some other teaching and other
I did some teaching
activities?
Also. So
we asked the questions, Dr. Bledsoe.
so, typical panels, I think, are upwards in the 100, 1,600, things like that. But now I'm growing again because I'm taking on other patients.
What's best practice? Is there like a national target they tell you all?
Yeah.
So it's a it's a little bit of a moving target. It's complicated. So I mentioned before that we're building this advanced primary care infrastructure. So a team takes care of a patient instead of an individual one-on-one, which is good. So you got the pharmacist to help out, you got a nurse to help out with complicated patients, and nurse practitioners and physician assistants can also be part of the team. So a physician and a team, maybe 2,000, 2,500, physician by themselves, 1,500 is really pushing the envelope in terms of just being able to see people when they need to be seen.
Yeah.
All right, I'm overdue for a break, so we're going to do that right now. When we come back, I want to get inside your practice and try to get an understanding of what you guys deal with on a day-to-day basis. Stay with us. You're watching Newsmakers. Welcome back to Newsmakers. I'm Tim White. This is Ted Nesi. We're having a conversation about the primary care crisis in Rhode Island. Our guests are Dr. Mariah Stump and Dr. Thomas Bledsoe. I want to read something to both of you. It's a sentence from an opinion piece from Commonwealth Beacon. Dr. Eric Dixon writes, quote, "Our primary care providers want to see more patients and improve access, but they are unable to do so because they are completely overwhelmed with non-patient facing administrative duties," adding, "We do not have access to primary care providers in this state," meaning the Commonwealth, but I think it's true here, "because we won't let them do their job, primary care." Is he right?
I think to a certain extent he is.
So what is he talking about with administrative duties? Give us some insight.
Talking about the work we take home, right? So for every patient facing 30 minutes, we might do 10 to 15 minutes of documentation when we're home. So if you add that up with, 15 to 20 patients a day, that ends up being sometimes hours of
So
work.
that's like pre-authorizations.
That could be that, or just literally typing notes, doing scripts, doing messages. Lots of patients have access to the portal, so they can contact us at any hour, and so we need to respond to those. So it's a lot of taking home of work.
Have you seen it increase over the 30 plus years?
Yes. So dictating notes into my dictaphone back in the day and paying 9 cents a line and then 16 cents a line and so on.
Wow.
But it was an after hours task. So seeing patients and documenting and ordering and reviewing their labs when they come in the next day, all that administrative work is really a significant part of the package.
Well, it's striking to me, and sorry, Ted, I'll get to you, but I'm reading a doctor in Massachusetts, and the first half you're saying, 20 to 30% more, and they're facing a primary care crisis. He's putting it on the administrative duties and whatnot. I mean, what's your reaction when you hear they're paying more, but yet they're facing the same thing as we are?
Well, I think it's universal, the things that doctors are dealing with in terms of like how much we call it pajama time, how much you're doing after hours, then you're not in work. So, but if they're having a problem with it in Massachusetts, then you can only imagine what our doctors are dealing with.
Fair enough.
So could you just walk us through, I'll stick with you, Dr. Stump, like what's a typical day like in your practice? And I know we always say we don't have typical days, maybe you feel that way too, but if you imagine what one would be like.
Yeah, so we typically see, if it's a full day, I see patients a little bit later than some of my colleagues, 8:30, 8:45, and I'm done by 5 so I can go pick up my little one. But fielding lots of things. I think it's the input. You're constantly dealing with telephone messages that come in that patients need quick answers during the day about something that's happening with them urgently. We have to do that. We have to do labs that come back. We have to deal with office messages if there's anything to deal with, and then we also actually have to see the patients, which takes a lot of time. And then there's always the documentation. So you add that up, and if you're seeing a full day, you may not get to all of those things until quite after the regular business hours are over.
I was struck by something you said earlier, Dr. Bledsoe. You mentioned you were talking about keeping graduates here because Brown obviously has a great reputation, but those students can go all over when they graduate. I just saw the match list someone flagged to me at Brown Medical for this year. And this doctor pointed out to me, out of over 100 graduates of medical school, only a handful are going to do a residency in primary care in a Rhode Island hospital. I realize Brown is a global institution. It's an Ivy League. At the same time, it is supported in part by its tax breaks and rounds. Does Brown need to do a bit more to try to steer more of the medical students there into Rhode Island primary care, or is it just impossible because of the rate situation?
I think so some kind of commitment to practice in Rhode Island as part of perhaps the funding support for the tuition is definitely a possibility. Whether how Brown would do that or if it would be a state program is open for discussion. But Brown can't really mandate where their students go.
Of course, yeah.
You attract the best and the brightest, and then they have options ahead of them. So I think it's more about making Rhode Island a place that you want to stay and practice. Having some support, people are coming out of residency with incredible medical debt, and the salary options that are out there for them just for careers, let alone not just in primary care, are wide. And that is definitely a factor. So
well, I wonder.
Oh, go ahead.
Well, a couple minutes left, so you kind of bring it up, and I do wonder if that's another huge factor here. I mean, you both have chosen to be internist primary care physicians, where it seems like the money is in the specialty care for doctors, and that more and more of them, anecdotally, are going into specialties. Is that also an issue?
I think it is. It's a bit frustrating. We put in a lot of hours. Why our thinking, procedures are reimbursed a lot higher than actually sort of, we call it our thinking time. But with any other field, if you contact someone after hours, you're going to get billed for it. We're not billing patient for portal messages. I'm not necessarily saying we should, but there's a lot of things that we do that really aren't compensated for, and it does add up.
What do you think, Dr. Bledsoe, with the question of medical school, there's this bubbling up conversation about a state medical school, maybe that is partly seen to have lower debt loads coming out and maybe to have more of those folks stay here. Do you think it's worth studying?
So putting together medical school is really complicated. And Brown is doing a yeoman's job, but a lot of work to line up faculty for the students that they have. And it's a lot of work to take on students. So we had students earlier this week, and it gums up the workload. It's wonderful, they're great, they're curious.
Like interns.
And but to think that there's a whole second crop of potential faculty in Rhode Island to staff a medical school, I think is a reach. And if the governor wants to study something and have an answer in a couple of years, studying and putting together a medical school is probably a decades project, not a year's project. So it's not going to help us in the short term. And again, we want the best and the brightest doctors to stay. So it's about making the environment and both in practice and Rhode Island.
15 seconds, Dr. Stump. What's your advice to someone out there looking for a doctor right now?
I guess, right? No, I'm kidding. No, just, contact, I think we should get a state registry or something available so the practices will put out who is accepting new patients and make that publicly available, either the Department of Health or on the news or somewhere, because patients are really just using word of mouth, and that's tough.
Dr. Mariah Stump, Dr. Thomas Bledsoe, thanks so much for joining us on the program. When we come back, House Speaker Joe Shekarchi was our guest, and he was asked about the primary care crisis. Stay with us. You're watching Newsmakers. Welcome back to Newsmakers. I'm Tim White. House Speaker Joe Shekarchi was our guest on 12 News at 4, and among many other things, he was asked about the primary care crisis by Kim Kalunian. Take a listen.
I want to start with the same question I asked Governor McKee just yesterday. Rhode Island is already facing a primary care doctor shortage. Anchor Medical is closing. They're citing low reimbursement rates as one of the reasons that they're shutting down. Is it time to stop studying the issue and to actually raise those reimbursement rates?
I believe it is. Unfortunately, the governor's budget gave me $0 for those, so we're looking at that. This is an extremely challenging budget year. As we continue to examine the budget, there are a lot of articles that have, financial impact that is not certain, and I have a real problem including them in the final budget until I know if we're actually going to generate revenue. So we're looking at that. If there's any of the money, I can tell you that most of the majority of my caucus want to see any money be put into primary care physician reimbursement rates. But beyond that, beyond the money end of it, there are a whole host of bills we're working on to make it easier for primary care physicians to operate. I want to point out to you that I don't have a primary care physician.
You don't?
No, my primary care physician retired in October. She's younger than I am. She's burnt out, and she moved out of the state into another location. I'm not even sure she's going to practice there. But the reality is I am one of many people, so I know what it's like to look for a primary care physician. I do not have one.
So you're trying to find a way to make it happen this year, but it might not be a possibility.
We're going to do our very best. I hear the primary care physicians loudly and clearly, and I hear their needs, and I'm very sympathetic. My dad was a practicing physician in Rhode Island for many, many years, so I believe, they deserve to be paid an honest day's wage for an honest day's work. And right now, the system is at a straining point, and they're working very hard, and they're working for very little.
Speaking of the money crunch, I spoke with the governor about this yesterday, too. His request to give raises to 11 directors in his cabinet, including Rhode Island DOT Director Peter Alviti. You've said it's not a good look given the financial constraints. Are you going to veto those raises?
Well, I don't get to veto. The House will vote on it, on that bill, and then it goes over to the Senate. In order for those raises to stop, both chambers would have to approve the, it's called a concurrent resolution.
Okay.
And then it gets transmitted to the governor. And the governor can either accept that or he can veto that as well.
Okay.
So the veto power rests with the governor, not the General Assembly. I will tell you that I had a caucus recently with my members. The overwhelming majority are not in favor of the raises. It's not the amount of money. The amount of money is about $90,000.
Sure.
It's the optics. We're asking people to cut. We have low reimbursement rates for doctors. There's being cuts, federal cuts, all along the spectrum of continuing care, but all across Rhode Island. And then we're giving raises on top of the raises that we gave everybody, which is about 12% that went into effect this July 1st. So it's very difficult in the optics, and it's not anything personal. I like all the directors. I have nothing against them, and I just think they should all wait until next year.
Okay, I want to ask you about Providence Mayor Brett Smiley is asking the General Assembly to allow him to exceed the current 4% increase on taxes in the city. He wants to hike them 7.5% this year. Are you on board?
Not yet.
Okay.
We have to have hearings on that process. We had hearings scheduled at the request of the city and the sponsor. They asked that it be delayed. Typically, on these kinds of requests from municipalities, we generally do support them when there is a city and town council resolution in support of it. That is the case now in Providence. It wasn't the case before. We're actually going to have hearings on these bills next week. I invite the public to participate and have their views be heard on it. But I will tell you there are several different competing levy bills. It's not just one bill. It's not a yes or no. We have to decide which bill we're going to decide to move, and then there'll be a vote in the House floor on it.
Obviously, you're very busy behind the scenes with the budget. You spoke about that a little bit in your first answer.
I was working on it all day today.
Okay, so what are some of the issues that are rising to the surface as you're trying to get that done?
Revenue, and more revenue, and lack thereof. How do we make it up? How do we, and we have to pass a balanced budget. Every budget I've passed since I've been speaking has been bipartisan, and it's been a balanced budget, and we have to do it again. And it's extremely challenging this year because so much of what happens in Washington has a direct impact on Rhode Island's budget. So it seems like I used to say every day things change, but now every hour things change. So we're going to do our very best with the information we have, and we'll do our best to serve the people of Rhode Island, but we will pass a balanced budget. It's our constitutional obligation, and we will fulfill that obligation. And
just quickly, before I let you go, your name has been floated a lot as a potential candidate for governor in 2026. What do you say to those speculations?
I don't participate in that. I tell people that the best thing I can do for the state of Rhode Island and for my political future, if there is one, is to be the best possible speaker I can be, and that's what I intend to be, and we'll let the future worry about itself.
All right, so no announcement for governor today?
No announcement today, and if I did, I don't think your husband would like it. Okay,
we're talking about Ted Nesi here. All right, House Speaker Joe Shekarchi, thanks so much for being here.
Thank you. He'd want me to announce on his show.
Fair enough.
Little gentle reminder to the House Speaker. This is my show, Speaker, not his. Happy Easter to everybody. TJ Del Santo tells me it's going to be a nice one, so enjoy it, and we'll see you next week on Newsmakers.